Hi everyone, Dr. Lazier here again, part two of caring for the pregnant woman. Okay, we left off talking about hormonal changes. The placenta secretes a hormone called placental growth hormone, supporting the growth of the fetus. And placental growth hormone and other placental hormones are counter-regulatory to insulin. That means that all women who are pregnant undergo what we call a diabetogenic state. Now, women who don't have a history of diabetes in their family, women who are not overweight or obese, or have other risk factors, can compensate for that insulin resistance that's normal during pregnancy. But many women do not and have gestational diabetes, and that's one of the reasons why. And after the pregnancy and the placenta is delivered, she no longer is exposed to those hormones. However, it does mean that she's at greater risk for developing diabetes in the future. Relaxin's a hormone that helps um, make the connective tissue more amenable to delivery. And erythropoietin is a hormone that helps with that increase in red blood cell mass. Remember, we talked about how much greater the cardiac output is in pregnancy. And the basal metabolic rate goes up 15 to 20%. Now we'll talk about care during pregnancy. Usually the first prenatal visit is 8 to 10 weeks gestational age. This is a comprehensive visit. You'll confirm the pregnancy. We'll talk about methods in a bit. Get a good medical history, review of symptoms, psychosocial history. Ask her what this pregnancy means for her. You don't want to do a whole prenatal workup and find out a woman's thinking of terminating a pregnancy. It's something to find out up front. What's her family situation? Who does she live with? What's her reproductive history? Were there other pregnancies, and what were the outcomes of the pregnancies? You want to get a good menstrual, contraceptive, and gynecologic history. Her nutritional state at the time of conception is extremely important. If a woman is not taking, say, adequate folic acid, there's an increased risk of neural tube defects. That's why we fortify bread with folic acid and other products. What's her sexual history? Is she have a history of gender-based violence? Is she at risk for STIs? What are her habits in terms of smoking, drug use, either legal or illegal? Doesn't matter. It all affects the fetus. Surgical history. Remember the importance of uterine scars and whether or not a woman will be able to have a vaginal delivery. If she's had a classical incision, then she'll have to have a cesarean. Determination of gestational age will be done at that time. You might send her for an ultrasound to confirm that. Medications, any kind of complementary therapies, herbs. A lot of people don't consider, say, St. John's wort or something like that to be a medication. So you have to really stress everything goes in her mouth you need to know about. Do a head-to-toe assessment. The BMI is very important. Vital signs, checking all the different systems. Make sure and check her oral health and refer if there's any issues with her oral health or her gums. ENT, of course, you're going to check her thyroid and TSH in the labs and do a breast exam. The fundal height is measured from the top of the symphysis pubis to the top of the fundus, which is the top of the uterus. Speculum and bimanual exams are done, and you test the adequacy of the pelvis to see if you think she'll be able to deliver vaginally, because some women can't if the baby's too big for their pelvis. That's called cephalopelvic disproportion. So these tests here, I'm not going to go into too much because you will learn these in OB, and they look more complicated than they are when you do them. It's not so hard. They're just ways of testing the adequacy of the pelvis. You will do a breast exam. Remember to look and see if the woman has inverted nipples. If she does, there's things she can wear in her bra to make the nipples more prominent so she won't have trouble breastfeeding. You'll check the genitals for any kind of lesions and do a speculum and bimanual exam. Then when you're doing the bimanual exam, you can be looking to see the size of the uterus, or feeling for it, I should say. Okay, so then you assess for other pregnancy changes. You can see the striae on the picture on the right, and the linea nigra, particularly on the picture on the left, checking for scars, surgical scars on her abdomen that may be clues to uterine surgeries. The uterine size, in the first trimester, you do that via the bimanual exam. Remember the landmarks of the symphysis pubis and umbilicus. You measure the fundal height, sometimes called the McDonald measurement, starting at 20 weeks. And at 20 weeks, the fundal height should be right at the umbilicus. After that, it should go up 1 centimeter a week. So at 32 weeks, the woman's fundal height should be 32 centimeters. That's give or take a centimeter or two. I mean, there is some variation, but if you find that it's, the fundal height is lagging or increased, that is an indicator of various types of risk conditions that need to be ruled out. Okay, blood tests are done at the first prenatal visit, urinalysis, pap smear if she hasn't had one recently, and STI screening. Here are a number of different labs. I'm not going to read them to you. You can look at them on your own, and it tells you what they are and when they're done. So the first labs, we're going to, of course, get blood type and Rh, antibody screen. You should get a CBC, pap if needed, varicella and rubella. Varicella can cause problems for a fetus, but rubella is the worst known teratogen that we know of. It causes terrible birth defects, so we do want to know a woman's rubella status. And hopefully she's been immunized and she's immune. If not, when she delivers on her way out of the hospital, they'll give her the vaccine, so the next pregnancy is not at risk. VDRL, urine culture screen, they're going to get a hepatitis B. If a woman is a hepatitis B carrier, then we can give the baby, immunoglobulin and H-bigot when it's in the newborn nursery to prevent transmission. And usually they do not, it isn't a problem because we can immunize the baby. HIV, if the woman's positive, we want to get her on antiretrovirals, and the baby will take them after delivery. There's a whole protocol for that. And the transmission rate has become very low, like under 1%. Chlamydia can cause either and gonorrhea can cause eye problems, chlamydia for the baby, and chlamydia can actually cause newborn pneumonia. So we definitely screen for those, not only early pregnancy, but later in pregnancy too, because women can contract these diseases during pregnancy. All right, so based on her history, where she lives, there might be a PPD. 1 hour glucose screen early in pregnancy if she's at risk for diabetes and she's not already diagnosed. Genetic counseling, say for instance, a woman's partner, the father of the babies, has a child from another relationship with Down syndrome. That happened to a friend of mine. And so they'll do genetic counseling at that time. They'll check the TSH and other labs as needed. Now, other OB labs, 24 to 28 weeks, you're going to check the CBC again. That's where the glucose screen comes in if the woman was not tested early due to risk. Antibody screen, and if she's Rh negative, they'll give her RhoGAM. 32 to 36 weeks, we're going to do the CBC again, GC chlamydia, and group B strep. Now, group B strep, which many women colonize in their reproductive tract, doesn't cause a lot of problems, except in the case of newborn babies. If exposed to GBS during a vaginal delivery, it can lead to neonatal sepsis and could cause very serious sequelae. So if she is positive GBS in that around 36-week time, she will get antibiotics in labor. If she's scheduled for cesarean, she doesn't need the antibiotics. It's only for babies born to vaginal delivery. There's another type of newborn sepsis from GBS, but that's late onset and it's not related to delivery. Okay, so how do we date a pregnancy? Everyone wants to know when they're due. You can do the Nagel's rule, or you can check the size. And the definitive way is early ultrasound. You can see on the right that tiny little fetus, and that is the most accurate way to check it. Actually, I have an app that I use, and a lot of people just use apps or wheels. Nagel's rule. You should know how to do this. Add 7 days to the first day of the LMP. Subtract 3 months, and don't forget to use the actual days in the month when crossing over to another month. So here's an example of some math. I'll let you kind of practice that on your own so you can learn how to do Nagel's rule. Okay, so you can use these pregnancy wheels. When I worked in L&D, we always had these. And then eventually, you can tell I put that picture up there a while back. That's a very old-looking phone. But there are apps, your phone, your iPad, that can give you all kinds of information about the EDC, the estimated date, due date, and how big the baby would be, etc. Okay, so ultrasounds, early ultrasounds are extremely effective. This is within 3 days, due date will be calculated 90% of the time. If done between 7 and 10 weeks, if done in late pregnancy, they're very ineffective in dating, but they're very effective in the beginning. And you can see that really pretty good ultrasound there of this tiny little fetus. Okay, so we always check the fetal height to look for growth, fetal heart rate for viability at every visit. The heart rate should go from 120 to 160. Around 18 weeks, they do the anatomical survey to rule out any kind of anomalies. This is a big deal because for a lot of women, because they find out the gender, and I guess now they didn't have this when I was having kids, but they have gender reveal parties. And genetic testing will be done as indicated. Okay, so return OV visits, you're going to get, each time you see the woman, you're going to continue to risk assess. If there were some risks on the problem list that were noted early on, you need to keep assessing. Say she had history of substance abuse, you would ask her about that, maybe do a test for it. Always assess for psychosocial risk, does she have what you need for the baby? Is she supported at home, etc. You always get weight. It's important to look at weight, either too much or too little. Dipping the urine for protein, glucose, and ketones. Fundal height will be measured. Remember, from 20 weeks on, it should correlate with the number of centimeters of the week, should correlate with the centimeters. Always check for the fetal heart rate and the Leopold maneuvers. And one of the things I'm going to tell you guys as novices, make sure that fetal heart rate is the baby's and not the mother's. Check to see what her pulse is. And the Leopold maneuvers are done to assess the position of the baby, and we will talk about that in just a bit. Okay, so 15 to 20 weeks, she starts coming in every 4 weeks for prenatal care. And during that time, they'll do the multiple markers tests, and that'll look for things like neural tube defects, screening for Downs and other genetic abnormalities. The 1-hour glucose screen is done on all women around that time. If she's, it's only done for women that are at risk that haven't already had it. It gets done at a later time, and I'll get into that for everybody. The ultrasound may be done to date and survey of fetal anatomy, as we talked about, around 18 weeks. 20 to 24 weeks, you start preterm labor education. Okay, women do not always know the signs of preterm labor and may not realize that some cramping or pain radiating into the thigh, or all kinds of things can be preterm labor. 24 to 28 weeks, that's when you're, if she's at risk for preterm labor, you want to see how long the cervix is. The first thing you'll find is sometimes is cervical shortening. She doesn't have to have contractions for that to happen. A 1-hour glucose screen is done between 24 and 28 weeks. That's for everybody. There's a contraceptive dialogue. We want to start that early, and we should start talking about infant feeding, breast versus bottle. Of course, the American Academy of Pediatrics and everybody else recommends breastfeeding, unless the woman is HIV positive or has some other kind of risk factor or problem. Almost everybody should breastfeed, and we should be encouraging and promoting that. Remember to be looking at her nipples and seeing if she has any need for for that to be addressed. 28 weeks, these are coming every 2 weeks. Hematocrit, hemoglobin, RhoGAM, nutritional follow-up. We're always looking at weight, nutritional status. 36 to 40 weeks, she's coming in weekly. She's asking you when this is going to be over. Just please get this over with. That's about the stage women are pretty tired of it. They get lab tests, review signs of labor, and discuss plans for infant feeding again. Okay, so I'm going to talk about Leopold maneuvers in the last section. So this is the end of this section.